to another interesting topic which is coming up, and which is going to be a challenge in our country with a lot of young people and the diabetes incidence coming to lower and lower age. And we have a very wonderful topic of approach to type 2 diabetes in patients younger than 25 years, or they are in their youth, who are going to be exposed to the hyperglycemia and the treatment for a long time in their life. And how are we managing these? What are the medications approval in this time? We are going to have Dr. Arundhati Dasgupta, a dynamic endocrinologist from West Bengal. She has innumerable feathers in her cap, and a very passionate and wonderful person, good clinician and researcher. I would request Dr. Arundhati to take over the session, introduce her panel experts, and start the session. Arundhati?
So much. Thank you so much, Dr. Anjali, for that very kind introduction and such a wonderful. It's a pleasure to be here in such a wonderful program. I was just hearing
Pleasure
the other.
to have you.
Thank you. So, as Dr. Anjali said, our topic is a very relevant topic, and with the increase in the number of diabetics in the world, and particularly because India has a large share of young people, because we start our diabetes almost 2 decades earlier than the others. So we have a huge chunk, a huge burden of diabetes of people lesser than 35 initially, now almost 25, because we're seeing a lot of them. And they come with an entire spectrum. Say around 3 decades back, we thought of young diabetes less than 25 years as only type 1 diabetes. But across the spectrum, we've seen now type 2 and even other types of diabetes, which we'll be discussing subsequently. And to go through these discussions, we have 3 experts with us. Firstly, we have Dr. Shaila Sheikh. I think Dr. Sheikh needs no introduction. She is a very prominent face across all the diabetes meetings and across the country. And she's a consultant endocrinologist based at Mumbai. She has her career highlights, as you can see, are many. I'm sure a lot of you know about them. So welcome, Dr. Shaila. Our next expert is Dr. Shalini Jaggi. She is a consultant diabetologist at New Delhi. And like Dr. Shaila, Dr. Shalini also is a very, very prominent face. She's a very active person across various groups and a very, academically oriented person, as we will see as we go through our discussions. Welcome, Dr. Shalini. And the third expert is Dr. Mithun Bhartia. Dr. Mithun Bhartia is a consultant endocrinologist based at Guwahati. And as you can see, he also has a number of feathers to his cap: Rising Star Diabetes, India, UK, and amongst the others. So welcome, Dr. Mithun.
Thank you, Arundhati.
So do we have Shaila and Shalini? Yeah, I can see.
Yes, hi.
Right. Hi. So as we were discussing that, it's diabetes in the young. It has become a challenge because we have become a kind of oriented to the fact that diabetes in the young can be so different in each different individual. So we will start off our discussion by a presentation by Dr. Mithun, and then we'll take the questions thereafter. Dr. Mithun, could you please share?
Thank you, Arundhati. So at the outset, I would thank Dr. Neeta Deshpande, Dr. Sanjay Agarwal, Dr. Anjali for the kind invitation, and Arundhati is my batchmate, so it's very nice to have it with my batchmate and my other friends as well. So I've just brought a case out here, which seems very simple, but seems to be very common that we may get in our clinic. So a 25-year-old male had a routine health checkup and had a blood sugar of 280. His elder brother is also been diabetic. Sometimes we get vague histories. He says his brother is diabetic. We don't know what onset, what not onset. We do his pulse, blood pressure, other observations. He's fine. He's not toxic. He's not in diabetic ketoacidosis. As you can see, very much there's no ketonic breaths or a fruity smell from his mouth. And his basic bloods like creatinine and lipid profile are normal. His blood count's normal. His BMI is 20. And his urine ketones are negative, because that's something which we can do in our daily practice in our clinic. When we send his bloods, we have sent for urine ketones. So this is something which can come across and which very often comes across, as Arundhati is mentioning, traditionally used to have only young as type 1 diabetes, and now there's a lot of clustering in between and having a wider spectrum. So this is something which can come to our clinic at any given point of time, a well patient with this.
So yeah, Dr. Mitchell. So could you give us an idea as to how we would approach this case? The first thing I think that would be there in our minds would be to differentiate, given that his BMI is on the leaner side, to between type 1 and type 2. So could you give us some points that would help us differentiate between type 1 and type 2? And as you said that the urine ketones are negative, would that put it in favor of type 2? Or would there be other tests that you would be doing? Because you've mentioned certain question marks out there, blood ketones and C-peptides and antibodies. So how would you differentiate between the two, type 1 and type 2?
So I think, see, when we are doing urinary ketones, we are checking the ketones that are in the urine from the last time the bladder has been evacuated. If the bladder hasn't been evacuated, the patient is dry, we are not going to get any urine ketones. Now, when there is insulin deficiency, the fat metabolism has been started to get, we want to get energy from there, and we get production of acetoacetate, acetone, and beta hydroxybutyric acid. Now, if you look at the actual ketones, the beta hydroxybutyric acid and acetoacetone is in the ratio of 10:1. And in the urinary ketones, we generally get acetoacetate. So that's why even if we are treating a case of DKA, we might get a prolonged phase of urinary ketones because the beta hydroxybutyric acid is being slowly converted into acetoacetate, which we are going to get in the urine ketones. The blood ketones, on the other hand, predominantly measures beta hydroxybutyric acid, which is one of the main ketones that are there. So having a blood ketone meter in the clinic is a very useful parameter for this patient. You may don't want to do urine ketones, that's fine, but a blood ketone would help us actually determine whether the patient is producing ketones or not, because we may get 1.5 kind of diabetes as well, in which type 2 patients will produce ketones as well. So that is one important parameter to think about having it in your clinic or sending into a lab to estimate beta hydroxybutyric acid to get the blood ketones, which is very, very specific. You also mentioned, Arundhati, how we can differentiate between the two. I think if we have to look at what does the patient, if the patient doesn't have acanthosis nigricans, is not obese, his lipid profile is fine, uh, then, and there is no family history. Family history is very important, but family history is very difficult. That doesn't mean that if we don't have family history, they cannot be something in the familiar. So there is a very good website, Diabetes with Genes. There's a calculator by Exeter in UK. So you can, plot in all your things, age, onset, blah, blah, blah. There is things, and it will give you a risk score for actually screening for familial conditions that are there, because this may be a MODI that you may be facing, but that helps us practically use it in our clinical practice. The Diabetes with Genes calculator, which is there in the website. And traditionally, you differentiate with type 1 because if they have had a well period without insulin, type 1 cannot survive without insulin. So if they've had a well period without insulin, especially if it has been a prolonged period of time from diagnosis, and they've responded very well to sulfonylureas. Sulfonylureas, what we have traditionally talked about, Modi, but I found there was a lot of articles even on use of netaglenite. So we have repaglenite in India as well. So I think they may respond to that as well, not traditionally sulfonylurea. So if you find that that is there, and especially we want 3 generations because they're autosomal dominant, but you may get up with 1 generation. Patients don't know we live in nuclear families nowadays. Previously we used to have the whole family coming. Now we get small families coming. So we don't know who's who and who's what. So that may help differentiate between the type 1 and the type 2 classic picture with Modi. You're on mute. You're on mute, yeah.
So regarding the C-peptide and the antibodies, when is the best time to check them? And at times, maybe, these patients, they would have been treated outside with insulin, maybe. Say, supposing the patient was treated with insulin, he's come to you after about 1.5 months or 2 months after diagnosis. would you still go ahead with the C-peptide and the antibodies, or is it, because the patient has already been started on insulin, would that make a difference?
I think generally the concept of C-peptide is that pro-insulin gives us insulin and C-peptide. So that is where the C-peptide comes in our body from. So that is from the endogenous one. So and the reason we can estimate C-peptide better than the insulin levels, because they have a prolonged phase in the body. They do not get degraded as fast as the natural insulin which is there, and hence measuring insulin levels is of not much use, but measuring C-peptides has some value to it. But you asked the right question, is if we are faced with a patient who's already on insulin, comes to us in the clinic doing well. See, the lot of thing is how the C-peptide is taken, because if you're going to take it, you must take it in EDTA bottle. If you're going to tell in the gel infused bottle, then it has to be taken in ice, and the lab, it has to go to the lab straight away. And there's a cost associated with C-peptide. So a low C-peptide can be helpful, but still patients may be in a prolonged phase in which they may, it may not be as useful that doing it after 2-3 years of diagnosis. That is much better, because exogenous insulin has no relationship with the C-peptide that have been produced. In terms of antibodies, if they're positive, there is some value. If they are negative, it doesn't kind of rule out type 1 diabetes. So a balance has to be with the pocket of the patient, especially whether they can afford these tests, and whether our pen prescription is going to change with what we are going to see.
We'll take a quick question for Dr. Sheila. Dr. Sheila, given the presentation of a lean diabetic, and he doesn't appear that sick, would you think of any other diagnosis here? Would you want to rule out any other, causes of high blood sugar in a young lean diabetic, apart from type 1 and type 2 diabetes?
Arundhati, another diagnosis, especially which would have a lot of significance if you are from a tropical country like ours, and especially if you're a South Indian, would also be FCPD, because we all know that fibrocalculous pancreatic diabetes is, though, an uncommon form of diabetes otherwise, but it is actually a result of chronic calcific pancreatitis in the absence of alcohol abuse. These patients will be lean, but the history is very, very specific, Arundhati. To present to you, they generally tell you, complain of recurrent bouts of abdominal pain and steatorrhea. And the diagnosis also, sometimes it is very, very diagnostic. You do a sonography, or you do a plain X-ray, and you find these large calculi or discrete pancreatic calculi. The problem is that, the exact etiology is still a little, there are many pathophysiologies which have been hypothesized. The diabetes in these patients is often brittle. It is difficult to control. And these patients, though, but the most important thing is that these patients rarely go into ketosis. So that is another thing which helps us as far as diagnosis goes. Of course, there'll be malabsorption, which will require, as we all know, pancreatic enzyme supplementation, sometimes surgery if there's intractable pain. And the most important thing is that we need to understand that they also develop microvascular complications, just like our type 2 diabetic patients. So I think, yes, this is one disorder which I would definitely keep in mind, especially if I saw a patient from the southern part of our country.
So do you recommend doing an ultrasound for every lean diabetic that you see? Just rule out
I wouldn't recommend it for everybody, but I would definitely listen to the patient very carefully. We are in an era where we do not really listen to our patients. And if our patient does give you any complaint of abdominal pain, steatorrhea, yes, that is something which I would definitely think in terms of.
Great. And we were discussing about Modi. Dr. Bharti was telling us something about Modi. Shalini, could you brief us a little bit about Modi and the other rarer types of diabetes, but which exist, which need to be kept in mind and definitely diagnosed if possible?
Yes, Arundhati, when we're talking of a young diabetic, I think there are a few differentials that need to be ruled out whenever you are evaluating a patient. And I think it's most important that you have a good history. along with the observation, because when it comes to history, I think Modi stands out because of the 2 to 3 generation history generally that you are able to elicit. We've had the Tatterson's and Fajan's criteria earlier, which used to actually talk about certain points, which means age at onset less than 25 years, a 2 to 3 generation family history, and autosomal pattern of dominant inheritance. So all those things, patient not really requiring insulin in the beginning. There are different types of MODI, monogenic diabetes. You have MODI 1, MODI 2, MODI 3. Of course, the GCK MODI or MODI 2 and the MODI 3s are much more common. What you need to understand about MODI is the presentation, which is little different. Usually they'll present with a very milder form of diabetes if it happens to be MODI 2, which is the GCK MODI, where you just have a mild fasting hyperglycemia or probably an impaired glucose tolerance. And most of them do not even need a treatment when it comes to GCK MODI. For the other MODIs, of course, it's important that you understand which form of MODI it is, because now it's mandatory that you do a genetic testing if you are suspecting MODI, because that only is going to tell you which exactly gene is affected, and that really impacts the presentation and the treatment strategy for the patient. So if it is one of those other MODIs where you can probably just put in a sulfonylurea, I think that works well. They do not really need insulin. On the other hand, you have the rarer types of MODIs. You have the KCNJ11, you have the ABCC8, the MODI 12, and the MODI 13, which usually manifest even as neonatal diabetes. So depends on the type of MODI that you are suspecting. So you have to keep an eye out for that. Moving on to the other forms of diabetes, we also have the ketosis prone diabetes or the flat push diabetes. That is common in the South Asian ethnicities, the Afro-Americans, the Hispanics, those kind of ethnicities, which is like an acute onset hyperglycemia, which is very severe. Usually they'll present with very high sugars, they'll present with diabetic ketoacidosis. At times they need hospitalization for management of DKA. So to start with, they will have, and essentially what's important is the C-peptides are good, the antibodies are negative. So these patients, they come to you almost like a presentation of a type 1. You put them in hospital, you follow the DKA protocol, you put them on intensive insulin regimes, and eventually they even go to remission. A chunk of them actually go into remission and they're well controlled beyond a certain point. The others may probably need only diet alone, and there's a segment that needs just diet and OADs. So the mechanism is not yet known for the KPD. But so all these differentials you need to keep in mind when you have a young patient coming to you. So it's not always that if it's a young patient, it's type 1 diabetes or type 2 diabetes. There are the other forms of diabetes that you need to rule out.
Great. That was very well wrapped up. So
I think
therefore, in this case, yeah.
Arundhati, if I could add,
Please.
like in a new marriage, everything goes hunky-ponky for the first couple of years. So in a patient who may have type 1 diabetes, all of us are smiling, I don't know why, but in a new patient who has got type 1 diabetes, you may have a honeymoon phase as well, in which suddenly you may want to stop all the treatment because the beta cell has been given enough rest. And when that flings over, gets out of the honeymoon phase, if you're well controlled, you may be able to prolong the honeymoon phase for slightly, long duration of time for that. So that is something to watch out. Sudden, ceasage of hypoglycemia on patients who have started on insulin, especially in this age group, you have to watch out for the honeymoon phase.
Absolutely, absolutely. So that about wraps up our case. A lean diabetic, a young lean diabetic need not necessarily be type 1. It can be type 2. It could be MODI. It could be FCPD, or even the rarer kind of flatbush diabetes. We'll go on to the next case, which is going to be presented by Dr. Shalini. Dr. Shalini, could you please take it? Yeah.
Yes, please. So are my slides visible?
Yes.
Yes. Okay. So friends, when we are discussing a young type 2 diabetic who's less than 25 years of age, and we've ruled out the other forms of diabetes, what we need to understand is from an Indian perspective, earlier the classification was anybody whose onset of diabetes is less than 35. And now we're seeing the adolescents, we're seeing the young ones, the 20s and the teens. So when you actually look at the etiologies for young, almost 40% is still type 2 diabetes, another 40% could be type 1 diabetes, and then you have the FCPDs, the MODIs, and all the other rest. And we've seen an exponential rise. So if you look at the differentials, you have all these differentials that we have been discussing. And there are the other forms that we're not going to discuss today, the gestational diabetes, obviously, the endocrine diabetes, and the rarer forms of diabetes. We'll stick to the most common, and this is the common occurrence that you usually see, the prevalence depending on the age of diagnosis. So the most common DDs that you need to keep in mind when you have a young patient coming to you with diabetes. But one thing you need to always understand is the data that today actually showed, the today study, which actually came out and said that there's a difference, even if it is, you diagnosing a patient who is not type 1 diabetes, a young patient coming to you with type 2. In the young, the beta cell failure, the deterioration is very fast. So what you need to understand is, any youth presenting to you with diabetes, the beta cell failure will be more rapid. So whenever you're looking at adopting a treatment strategy for them, it has to be very intensive. So the idea is not to waste a lot of time, and you need to be intensive, hit it hard, and get it down as early as possible, get them under control as early as possible. So with that, we move on to Khushi, a 23-year-old executive who's just undergone an employee health checkup. So when you inquired on the history, she gives you a history of PCOS, which was diagnosed during her teens. She did take a short course of metformin, and she discontinued, like most of our patients too, because she's just one of those happy-go-lucky, typical girl who loves eating out, socializing with friends, probably walking once in 2 to 3 days, quite casual about her health. She does give you a history of an appendectomy when she was 12 years old. When you inquire into the family history, of course, her mother does have type 2 diabetes and is well controlled on tablets. Her dad expired when she was very small, had a massive heart attack at work when he was 46. So when you've examined her, one thing that stands out is the BMI, because obviously she is 29.3. She does say she's had weight issues, but somehow she's just not taken it very seriously. When you're looking at her, you can see acanthosis nigricans with skin tags on the nape of her neck, and otherwise most of the other systemic examination is almost okay. Nothing stands out. Now, these are the lab parameters that spring out once you've evaluated her. She's, as you can see here, she's got diabetes. So there's hyperglycemia, there's HbA1c of 7.1, a fasting of 148, and a post meal of 220. You can see amount of dyslipidemia here. You see the total cholesterols of 200, triglycerides 220, and LDL of 130. GFR is 90, and you have a mild elevation in the liver enzymes as well, the SGOT and the PT, and we've already had a session on the NAFLD and the NASH evaluation just before us. So for this girl, she does not give you a history of any thyroid disorder, but incidentally, the TSH is 6.5 for her. So echo is normal. Ultrasound, of course, confirms the PCOD picture and comes out with something called a fatty liver grade 1. And we've had this discussion earlier, so we'll not stick on to that. Everything else seems to be quite insignificant. So what are the areas of concern for her? Of course, like I said, you've just picked up a case of diabetes, newly diagnosed. You know there are weight issues. There's PCOS in the background. There's a certain amount of dyslipidemia, the altered liver enzymes, a fatty liver indication there. And what about the status of the thyroid? So with that, I'll stop sharing and we can take the discussion forward. Arundhati, you're muted.
So this is the case like many others that we see in our clinic almost every day. A newly diagnosed obese lady with PCO, with all markers of insulin resistance, dyslipidemia, as you just. So the question being, we'll come to the pharmacotherapy later on, but we'll just discuss. Obviously, there is a strong role of lifestyle management in this patient out here. So I'll put my question across to Dr. Mithun. Could you just give us very briefly the lifestyle measures that you would advise for this patient, and would you, give lifestyle a chance for some time before going ahead with pharmacotherapy, or would you, directly say that no, okay, this is lifestyle measurement plus pharmacotherapy? I would like both of you, Dr. Sheila and Dr. Mithun, to take up this question on each. So maybe we can discuss lifestyle modifications and the MNT in a very brief manner.
So Arundhati, before we go on to that, just one point I wanted to make in this case, which is a very interesting point on thyroid. You see, TSH abnormalities can bring a polycystic appearance in the ovaries. So I think
and vice versa.
And vice versa as well. So that is something which we can know, and even polycystic and PCOS on itself can cause isolated elevation of TSH without abnormal, without doing that. So that kind of is very important, and a T3, T4 alongside would be very useful. So that is something I just wanted to bring it, because TSH may just auto-regulate itself. Now, I think it would be very important at this time is to get into lifestyle. I think a trial of lifestyle would really be, because that's the first point you want to impinge upon the patient to get into a lifestyle mode of action. And very often that's forgotten in a busy clinic. IDEC is known for excellent sessions on diet, and I think we had a big session on it as well every year. So I think that is something which we can actually push our patients towards, because moment a young patient finds a corridor of opening of not adhering to diet, they will actually grab it with both hands.
So
yes,
would you wait for lifestyle to give its results for a short period of time before starting off with pharmacotherapy in this patient?
so I think
It's
first
7.1.
it's important to know. So what I do in these patients is sometimes I put up a CGMS, because many times patient comes to, sir मैंने इतना चीनी खाया, ये खाता हूँ, वो खाती हूँ, इसलिए मेरा sugar बढ़ा है, whatever. So I put them an ambulatory glucose profile on them and say, I give them 2 weeks, do what you want, come back in 2 weeks time, let's see what your diet does to me. And then it becomes a greater meaningful discussion, whether you see now whatever you've tried for 2 weeks, I'm not going to do anything, and after the 2 weeks let's get on with some medication. So it becomes an easier point of negotiation with that, and it also shows us how much of the diet is actually infringing on his glucose profile.
So we can actually see the difference that lifestyle changes are making. Dr. Shaila, if you could tell us a little bit about the medical nutrition therapy.
Arundhati, I think I personally believe that lifestyle modification, especially in this age group, is something that we should be really emphasizing a lot more on. I think as Mithun was saying, because we are all very busy clinicians, at times you tend to sort of, not talk about it or not believe in it. I mean, unless we believe in it, we're not going to be that emphatic. So our biggest issue starts from there. And I believe it's not only a question of, giving a diet. I think it's a question of course, as we're talking now, increasing terms of DSMM, where we're talking about diet, exercise, but we're also talking about support systems. So we need to provide our patients with the required support so that they can sort of, it's very easy for us to chalk out a path, but if you don't give them the support to follow that path, it becomes very, very difficult. And then, of course, as Mithun is saying, I mean, I personally would maybe give a longer period of time for the patient to do well on lifestyle modification, and then plan out any kind of therapy if the patient is relatively asymptomatic, is having no other medical issues which need immediate urgent attention or urgent to sort of, to be looked into. And as far as nutrition goes, I think it's also very important that we are now increasingly talking about the order of eating food also, where we are increasingly saying that, if you simple tips like telling the patient to first consume the vegetables before they eat and go to the carbs right at the end of the meal, is going to make a bigger difference. There are studies which show the postprandial hyperglycemia which occurs as a result of just changing the pattern of eating is making a very big difference to what Mithun was saying, where we would actually see benefit as far as the CGMS is concerned. I think macronutrient composition also should be kept in mind. Sometimes we get very dogmatic about, do this and this and this. And I think finally we need to give the patients a little bit of, flexibility. I think if you're dealing with a young kid, as Shalini said, a kid who wants to go out, who wants to sort of enjoy life. So you don't want that patient to feel bogged down by the entire, issue of, it sounds like, oh my God, diet. I have sometimes kids coming to me back, Mom, I don't want to do this. And, especially if they come for a second consult, they're sitting grumpily across. I was told not to do this, and they're assuming, okay, you're just going to chew my brains. So I think I'll stop over here. But this is, I think, a better way of, really looking at LSMs. Sorry for so much time. Thanks. It's a very topic I'm very passionate about, so I can practically go on and on.
There's another, I would agree. And one small point I would add is using the word exercise, because using the word exercise can sometimes be very difficult for the patient to digest. Using physical activity is slightly a little bit more acceptable, like telling somebody you're obese and you saying something you're overweight. So it's just a little more, you can do that.
So he gives a lot of emphasis on the words that you choose. Coming back from UK, yes, gives, but it's important.
Tell our patients you're more healthier than required.
Yeah, I know. It kind of is far more acceptable. And also, I think if you get the family into the physical activity, it often helps. It does not come like an exercise to them. I think that is something which is
There's a lot of
often
time you
helpful.
have parents who are like really scared, who've seen these figures, and they're like, they've suddenly stopped everything for this child. They stop every carbohydrate, and all of a sudden they make him go out or her go out and start exercising. That's not going to happen. We have to realize it can happen for 2 weeks, it can happen for a month. Your CGMS in 2 weeks is going to come down, it's going to be very good, but she's not going to maintain it until she realizes herself. So we really need to, bring down the charged parents also a little bit and tell them, okay, fine, things are not that bad.
And
It's 1
it's
o'clock.
also the parent modulation, because you can't be having ice cream and telling the child bagal mein ki nahi bhai, you can't have ice cream. So I think parents have to take charge in actually seeing what comes in the kitchen for everybody, because that kind of is healthy for everybody.
It's a family effort. Totally agree.
It's a family.
But talking about pharmacotherapy, in case we decide we go ahead with LSM and MNT and things do not improve much, so what would be the pharmacotherapy of choice? How would you go about it? Let's ask Dr. Shalini about this.
So yes, I think I absolutely agree. For any patient, for that matter, lifestyle and MNT has to be very, very important. And I think it's the way you talk to the patient and convince the patient. Now, coming back to our case, she's a young girl who's an educated girl who's definitely having weight issues, and now all these small indicators and alarms have come in. So I think it's the way you convey to her. And when it comes to pharmacotherapy, I think since she's 25 years old, we do have the entire plethora of treatments available to us. But looking at her presentation, and especially with the background of PCOD, I think this is the typical ADA patient where you want to start with metformin in the beginning, along with probably the lifestyle and the MNT, and see how she responds to it. Maybe if the patient, there are a segment of patients where they are very clear that they will not be able to actually do all the intensive physical activities. They do not have the time. They want to do it, but probably they would need a little more support. So, and depending on the presentation of the patient, sometimes you need to start even with a dual therapy. So that is exactly where you need to think of a therapy that's going to aid her weight loss, as well as give her all the other benefits, the pleiotropic benefits that we talk of. And this is where, when we're talking of evidence-based medicine, you have the GLP-1 receptor agonists or the SGLT2 inhibitors, probably as combination therapies that I would prefer if I have to go in for an add-on therapy along with metformin for this particular patient. And obviously, even when it comes to the obese type 2 diabetics or the overweight pre-diabetic patients, the adolescent group who are less than 18 years, there's limited pharmacotherapy options that's available. We know metformin is indicated for this entire age group, but then there was nothing else that was available for a 15-year-old type 2 diabetic, besides, except probably for the insulin indication for the pediatric group. So I think this is where the Ellipse trial came in with liraglutide, which actually went on to show that if it is an adolescent type 2 diabetic where metformin alone is not working, probably you can think of a GLP-1 receptor agonist, the liraglutide 1.8 milligrams, that actually showed a benefit not only in HbA1c reduction, but in achieving a good fasting plasma glucose as well. When it comes to this particular patient, I think you just need to have a discussion with her. And if metformin also does not work very well, or she's not able to reach her targets, I think then as an add-on, the choice of drugs would be an SGLT2 inhibitor if it's going to be an oral, or if she's acceptable, a GLP-1 receptor agonist. We have the option of a weekly GLP-1, or we have the option of daily GLP-1s, and very soon we're going to have an oral GLP-1 as well. So I think pharmacotherapeutic choices, because this is one patient where if you are actually able to motivate the patient on lifestyle measures, on weight loss, on MNT, probably this is a patient where not only can you aim for an HbA1c of 6.5 to start with, and then you can aim for a remission of diabetes. This is somebody who's just started her journey of type 2 diabetes, newly diagnosed, and we know the lifestyle, the weight essentially are the background. So this is where, if you are able to actually work on the weight loss part, work on the lifestyle part, getting some discipline, doing things the right way, you can actually motivate her not only for a good glycemic control, but for a remission eventually.
So Dr. Shalini, one question: would you ever consider just giving the SGLT2 inhibitor or the GLP-1 receptor analog without starting off with metformin in such cases?
This one, since she's got a PCOD background, I think metformin definitely. Of course, if that is not there, and there are certain cases, see, it depends. This one had acanthosis, skin tag, so there's a lot of insulin resistance there. So you have to give metformin. Of course, patients who cannot tolerate metformin, who have the gastritis, the adverse events, the typical not able to tolerate metformin, gastritis, nausea, abdominal discomfort, there sometimes metformin may not be indicated, and you can definitely start with monotherapy with a GLP-1 or an SGLT2 inhibitor also.
Arundhati, I think if I can add something over here, by ethnicity, we have a great amount of insulin resistance.
Yes.
So if by the fact that, we are dealing with a young child who's ethnically an Indian, I think we would definitely, Shalini would think in terms of, at least having metformin on board. Adding or subtracting would depend upon what else we can do. And with Dr. with so much of information available on social media, I have realized that when you talk in terms of resolution and when you talk in terms of reversal of diabetes, that becomes a great motivating factor for our patients. The patients are more willing to listen because they believe that there's something which is very concrete, attainable, and which is going to be done. More than putting them on medication. So if you have that conversation with them where you're talking in terms, okay, look, you can get your diabetes can resolve, your diabetes can get reversed. I think that conversation is a very, very big key, especially in the younger age group, which, as Shalini is saying, educated girl, kids who are, and believe me, this has nothing to do with education also. This is only a question of us talking to our patients, explaining to them that, yes, this is doable. Till now, the moment you said diabetes, it was like this big, bad disease where just one,
it was a lifelong.
It's just a single way, no reversal in this entire road. But when you talk about saying that, no, you can really do something about it, I think personally that makes a very big difference. So the conversation which you have with the patient and the positivity which you sort of, infuse in that conversation, I think makes a very big difference, according to me.
Absolutely.
I think if I could add,
we have 12 and a half minutes, so I think we can have Shaila coming in with her case and then move on.
Can you remember you're in a panel with three ladies? You have to work your way to talk.
I've been out.
Mithun is going to not agree next time to come to a forum with three ladies. Okay, I understand we're running short of time, so I'm going to try to be really quick in this so that we just have the salient points across and then we can sort of have a heated discussion again. A very interesting, this basically, I'm going to take up from where Shalini stopped, talking about why are we so worried about our young diabetics. What we need to really understand is we spoke about adolescence. It is the intrauterine environment which could actually also be a very strong risk predictor for young onset type 2 diabetes, which is actually more prevalent in our adolescent female population. What is very, very interesting is that there's actually an inverse relationship between the age at diagnosis and the risk of complications. And what do I mean by that? That means every 1 year which increases in age at diagnosis is actually associated with a 4%, 3%, and 5% minute reduced risk of all-cause mortality, macrovascular disease, as well as microvascular disease. So the age at which you develop diabetes definitely makes a very big difference as far as our patients are concerned. Shalini already spoke about more rapid beta cell decline, greater incidence of complications, and of course, more micro and macrovascular issues cropping up. I'm going to just spend around 2 minutes on the today's study group trial because the data of this trial now, the data which has come is from the follow-up of this trial. This trial actually was done between 2004 to 2011, where 3 treatment effects were seen in a very, very young population, a population between 10 to 17 years of age. Now, this population, after completion of that trial, was enrolled in an observational follow-up study to understand what happens to these patients subsequently. And what were they evaluated for? They were evaluated for diabetic kidney disease. They were evaluated for hypertension, dyslipidemia, nerve disease. This was done annually, and retinal disease was assessed twice in a year. And friends, what was the end result? You would be surprised. And why am I saying surprised? Because, conventionally, when you look at that young patient in your consulting, you somehow do not tend to monitor that patient too much for macro or microvascular complications, whether it's a mindset. You often see patients who come to you post 10 years diagnosis, and you ask them that, did you ever get your urine micral creatinine ratio done? They will say no. Or was your fundus ever evaluated? And they will say no. And this data, I think, is an eye opener, because at this point of time, these patients were only 26.4 plus or minus 2.8 years. This is data of 2000. And the mean time, mind you, since the diagnosis was already 13 years. Now, what do you see in these patients? What you are seeing is hypertension, 67.5%, dyslipidemia, 51%, DKD, 54%, nerve disease, 32%. That's a huge amount of comorbidities as well as complications developing. Retinal disease, including, mind you, more advanced stages, 13.7% and 51% in the period from 2017 to 2018. That means 60% of the participants had at least one complication. 28% had at least two complications. Some of the risk factors were, of course, minority race, ethnic groups, and associated hyperglycemia, hypertension, and dyslipidemia. This, I think, is the most important message we as a panel and as a group want to give everybody listening to us today, is that you cannot afford to be complacent when you look at your young diabetic patients, when you're looking at that patient less than 25 years sitting across, because, mind you, there is a huge amount of comorbidity, associated mortality when you look at these patients. This is, I'm going to run through the next few slides because that was the most important message I wanted to give you. But when you look at nephropathy, blood pressure has to be optimized. If your BP is more than 95th percentile for age, sex, and height, definitely, we just spoke about LSM. We are speaking in terms of if the BP remains above the 95th percentile after 6 months, think in terms of antihypertensive therapy. It could be ACE inhibitors, it could be ARBs. Look at the diet protein of 0.8 grams per kg per day. Definitely, you look at UACR at diagnosis and annually. Evaluate EGFR, and in patients who have modestly elevated UACR between 30 to 299, think in terms of an ACE inhibitor and ARB, again, something which we do not routinely think in terms of, and a UACR more than 300, definitely think in terms, again, of starting an ACE inhibitor ARB. Nephropathy, continue monitoring, which would make a very big difference. Neuropathy, this is what you would do. You would definitely focus on achieving glycemic goals, cannot afford to overlook neuropathy in your patients. Retinopathy, definitely do a dilated funduscopy or retinal photography at diagnosis annually. If you can afford to do it less frequently, if you have adequate glycemic control and a normal eye examination. NAFLD, an entire session prior to this, so I will not go into the great details of this. We all have just been speaking about PCOS. We need to understand that oral contraceptives, mind you, friends, is not contraindicated in patients with type 2 diabetes. And we've already spoken about the benefit of metformin. The only thing I would like to add over here is long-term metformin, we all know, is associated with vitamin B12 deficiency. So please see to it that you replace it, especially in our vegetarian population, and increasingly the young population is turning vegan. So that is another area which you should be careful about. Dyslipidemia, as we all know, we again don't look at this very, very seriously. We know the optimal cholesterol goal should be an LDL less than 100, triglycerides less than 150. If the LDL is more than 130, we know that you should be talking in terms of good glycemic control and dietary counseling. But what we do not do is that if the LDL remains above goal, we are very, very resistant. A lot of clinician inertia to start a statin in a young population. We simply do not start statins in a young population for reasons which are really, I would love to know from my friends as to what do they think are the reasons why we do not start statins. TGs, the standard guidelines, which we all know. So yes, we need to understand, we need to take cognizance of the fact that complications do increase over time. They do affect this young population. They are more common in participants of minority race and certain ethnic groups. And we need to monitor our patients. We need to manage them very, very carefully. And of course, we need to very, very closely follow them up so that we do not end up with the huge amount of morbidity and mortality that we are seeing. Thank you very, very much for your patient listening. Over to you, Arundhati.
Thank you, Dr. Shaila. That was a very strong and important message. Complications are inversely proportional to the age of onset, and they need to be monitored just like in the age group above 25. We just have 4 minutes. I have an important area of discussion which we'll just try to run through. The subgroup of less than 18 years. 18 to 25, we are still, I would say, we are still following the guidelines. Less than 18 years, one question to each of you. ACE inhibitors in less than 18 years, do you use them if indicated? If you see an albumin creatinine ratio of, say, 250, would you start an ACE inhibitor in a child less than 18 years? Shaila?
Arundhati, I would first of all, when I'm talking in terms of microalbumin creat ratio, the one thing I would like to say is you need to do it at least 2 levels at 6-month intervals. There are certain issues also which come up with microalbumin creatinine ratio. For example, hyperglycemia can aggravate it. You can exercise. Once you've ruled out all these factors, I would still suggest you start ACE inhibitors after 18 years of age.
After 18 years. Statins in the age group of less than 18 years if LDL levels are high. Dr. Shalini.
Definitely, I think the first and most important message has to be the dietary restraint when you have a dyslipidemia, especially in this age group, and a good glycemic control bit, because we know high blood glucose levels are associated with hypertriglyceridemia. So you don't really need to treat the hypertriglyceridemia if it is a mild degree of hypertriglyceridemia. When it comes to an indication for statins for children more than 10 years, yes, there is an indication for use of statins now. If you feel the cardiovascular risk is high and if there's a huge degree of a high LDL level that is present there. So yes, besides the diet, besides the weight loss part, besides the MNT part, I think it's very important that if there is an indication, we should not be resistant to adding a statin there. Sometimes, because now we see MI is occurring even in 10 years old and 13-year-olds. You see angioplasty is happening in teenagers. So I think it's a very important message has to be, if your clinical jurisprudence and the patient's presentation demands it, you should not refrain from starting a statin even in less than 18 years if it is required with a very strong family history, high CV risk, a very high degree of LDL. So along with diet, lifestyle, weight loss, maybe a statin can be added in even less than 18 years.
And Dr. Mithun, NAFLD in less than 18 years, apart from weight loss and the others, would you recommend any therapy? Say liver enzymes are in 250s or 300s, grade 2 liver as per the ultrasound. Would you start anything else apart from the usual things that you would say in terms of weight loss? We just have 1 minute. Mithun, you are muted. Mithun, you are muted.
If the liver enzymes are severely out of order, I would definitely take a gastro opinion. That's for definite. There's 2 aspects I want to, and I've got 30 seconds to wrap it up. Please talk about sexual dysfunction with an adolescent. And I've learned this the hard way, because I learned this in England when I was talking to a young guy about complications, long-term complications. He said, I don't give a 4-letter word to your complication. Tell me what affects me now. And that's when you talk about it, he just changes the whole story. He's ready to participate, and you can use diabetes as a negotiating tool for that. So that often helps. And the other aspect which I want to quickly bring in is that we talk about coming in new onset type 2 diabetes in young. We should also be looking at preventing type 2 diabetes in the young. And we need to perhaps look at activities in the school, colleges, and education, and even in our own household. Because the moment you change lifestyle in your own house, you're doing your bit in your house to prevent a change of perception in the whole thing.
Absolutely. So thank you, all 3 of you. This has been a wonderful session. We have had a broad discussion on diabetes in the young. We could have spoken on and on for another 45 minutes, I'm sure, in another 45 minutes, because there is so much more to discuss. But all in all, we've realized that there's a wide spectrum of, of diabetes occurring in patients less than 25 years. Complications need to be looked into, and Mithun gave us a new perspective about a calculator which is available for assessing the genes and all that, the connection, what it could be, and also the blood ketones. I don't do it routinely in practice, but this has been an eye-opener. Maybe we could increase such practices. So on that note, I would like to hand it back to Dr. Anjali, the organizers, and we are 8 seconds before time.
Thank you so much, Dr. Arundhati, Dr. Shalini, Dr. Sahela, and Dr. Mithun. We had Dr. Fida Bachi, who is one of the member of the Today group, which has given these new insights into younger patients with type 2 diabetes, and she spoke wonderfully. And it was equally wonderful to have your thoughts at a national level on these things, because I am sure this is the time of, this is the problem of future for all of us, all young people dealing with this. And let's say 25 years from now, we are going to have to deal with things that we are not imagining right now. So it was a wonderful discussion, and it has given answers as well as a lot of questions for